Welcome back to Healthline. I'm Gregory Zarian along with Suzanne Watley. You can catch us here every Tuesday night from 7 to 8 p.m. on Charter Channel 280 or on the web at glendaleadventist.com/Healthline. And we have our very own YouTube channel, GAMC Healthline.
We've been talking about stroke with a stroke survivor, Elizabeth Manaserian. She is a commercial real estate agent here in Glendale, the owner of Vantage Realty, and also the president of Glendale Healthy Kids. And we are joined here in the studio now by the doctor who helped save her life at Glendale Adventist Medical Center, Dr. George Rappard. He is a board-certified neuroradiologist and a trained neurointerventionist. He earned his BA in history at UCLA and his MD at George Washington University, then completed a general surgery internship at the Medical College of Georgia. Also completed a diagnostic radiology residency at UC Irvine. At the University of Texas Southwestern, Dr. Rappard completed fellowships both in neuroradiology and interventional neuroradiology, neuroendovascular surgery, and that's where he did research to develop new ways of doing image-guided and minimally invasive brain and spinal surgery. Dr. Rappard returned then to Southern California, where he now serves as the director of the Los Angeles Brain and Spine Institute, which is located on Verdugo Boulevard here in the city of Glendale. Welcome, Dr. Rappard. Thank you so much for joining us here on Healthline.
Thanks for having me.
Could I have one of your titles? Just one? The George Washington thing sounded cool. My dad would be so happy.
Would you take some of my student loans too?
That's right.
Dad, will you take all the students' loans too?
Now you had some of your education in different parts of the country, but decided to return here to Southern California to set up your practice. Why is that?
You know, I grew up here actually, and my office is on Verdugo Boulevard. As a child, I spent quite a bit of time at the hospital there, growing up on Beulah and La Cañada. I think ultimately we come back to what's familiar to us. This is where I grew up. This is where my family's from, and it's a wonderful community. It's a beautiful community. And I love living in La Cañada. It's also just sort of nice, you know, tucked away in the hills and very accessible to everything around Los Angeles. But really the deciding factor for me was I'm in an unusual specialty. There's about 300 neurointerventional surgeons in the United States. And at the time that I completed my training, most of us were going off to universities, and there were really no jobs available outside of the universities. It was sort of a passion of mine to do this in the community because I thought that people in the community setting should have the same access to care as someone would who lived near a major university. So that's what I really wanted to do, and fortunately I was able to tie in being from here and wanting to go back home with finding a hospital that was forward-thinking enough to introduce this specialty of medicine into the community. And when we started this practice at Glendale Adventist in 2004, we were actually the first private practice neurointerventional center in Los Angeles. So that really had a lot to do with it.
Forward thinking, indeed. Glendale Adventist was the San Fernando Valley's first certified primary stroke care
2008,
center.
March 2008.
So it sounds like it's been a mutually beneficial relationship, yours and the hospitals. And it was at Glendale Adventist that Elizabeth Manaserian came to your attention. What kind of shape was she in when you first saw her?
When I came on the scene in Elizabeth's care after she had been transferred down to a step-down unit. She had been treated with medications, and that's when she had a really scary episode where she woke up in the morning and couldn't move her right side and couldn't talk. And I can just imagine how scary that was and how anxious that would have made her feel. That's when I got involved, consulted by some of her other doctors, and we pretty much took her straight to angiography, which is a procedure where we put a little catheter in the groin, run up to the neck, squirt down, and take pictures. And what I saw was really a lot worse than what I was expecting to see. I saw she'd had a previous angiogram which showed a tear in the carotid artery, which is a very important artery that runs from the neck up to the brain. And in this case, not only is it the carotid artery, but it's the carotid artery on the left side of the brain. So it supplies the part of the brain that has to do with speech, memory, understanding
Motor
language.
functions.
Motor function, you know, we could live with paralysis, but if you lose your speech functions, you will not be able to interact with the world, and you will be essentially vegetative, even if you could move. So we knew that she had a tear there. We knew it was a very important artery, but in the several days since she had had her first angiogram, it had actually significantly progressed to the point where the entire artery was almost entirely closed.
And what diagnostic tool did you use to determine her true condition?
Well, we did an angiogram. We ran a little catheter from the groin to the neck, squirted dyes, took pictures, and just compared it to her old pictures. And you know, lo and behold, we saw that she had substantially worsened. She was now having worse symptoms. She had originally shown up with a headache, and now she was starting to lose some function in the left side of the brain, the dominant hemisphere. And at that point, we felt like if we continued on our current course, she would either die or be vegetative.
So, Doctor, can you share with us what you did with Elizabeth?
Certainly. Her artery had started to close down even more than it was when she first got to the hospital. Now it was almost entirely closed. And we had to get it open. And we had to use a little bit of imagination to do that because it's not something that we normally see or treat, actually. The tear was all the way from the origin of the artery about here all the way up into the skull. And so what we did was we inserted another catheter through the catheter that was already in her, going from her groin to her neck. And that catheter had a stent. And we placed one stent and opened up a portion of the artery. But because the entire artery was torn, we had to place another stent, and then we placed another stent. And we basically had to place stents all the way up to the skull base. And we had to use so many stents because the length of the artery that was torn was longer than any stent that we had. And then we used, the tear actually went all the way into the skull base and into the brain artery. So at the very end, we had to use a special kind of brain stent that we had that is especially designed to navigate in the brain arteries, and that's how we replaced, that's how we repaired the artery that was in the brain. So we refer to it as a full metal jacket.
Is that right? Is that what it is? Okay.
Basically,
now you
Good
know.
to know.
had to reconstruct her entire artery with stents all the way from here down to here.
Well, we actually have the procedure. Will you walk us through the procedure that you actually did, or share with us what we're going to see?
I'd love to.
Great.
So this is a cartoon of an artery, and what you're going to see here is a little catheter running up into the brain artery, and there's the catheter. It's navigated through a tiny little wire that you see there. The wire that's coming out of the catheter is about the size of a hair. We go through with the catheter, we deliver the wire, leave the wire in place, and then through that wire we place a little balloon. This is, it's called the gateway balloon. It's very different from the types of balloons that cardiologists use. It's very slicker and it's very soft, and it's designed to be used for these very delicate brain arteries. If you look at that picture, you see a very thin artery. There's no thick wall like you have on a heart artery. The arteries in the brain are suspended in fluid. They're not embedded in muscle like a heart artery. So it's a very delicate operation, and the tools are very delicate. The balloon is inflated just enough to make room for the stent, which is the wire mesh tube that's going to go in there and permanently keep the artery open. And there you see the catheter with the stent, again being threaded through the tiny little wire that we've kept in place. And in this cartoon, the surgeon is going to basically unsheath the little tube containing the stent, and it's going to deploy, open up our artery, and you're going to see how that happens there. So here we're sort of pushing it out. And we're going to pull it back into the part of the artery that's narrowed, and you're going to see very slowly how it opens up here. Now I have to tell you, this is a technological marvel. These stents go down to about 2.5 millimeters in size. So these are tiny, tiny stents. And this technology of having a stent that gently opens up on its own, this is something that is normally seen only in stents about 5, 6, 7 millimeters in size. So the fact that engineers could take this technology and miniaturize it into something so small so that we can use it to treat tiny brain arteries is really wonderful.
How long have these stents been around? We
implanted the first one in California at Glendale Venice in January 2006. They had been used previously in the United States, maybe just a handful of times in other states.